Greetings. I'm really not trying to look smart. I can't see a thing without them, I've decided. It's real sad. Anyways, if you've seen my duck, let me know. I am going to be first recording about asthma. And this is covered in your Peds book starting on page 736. So if you don't have your Peds book out, you'll want to get it out. And I'm going to pull up the fast fact sheets. If you have any questions or concerns, please let me know and I'll be glad to help you. Alrighty. Asthma. Asthma is a common childhood illness, and in fact, it's one of the #1 cause for school absences. When we think about asthma, it's an inflammatory reactive airway disease that is commonly chronic and can be related to hypersensitivity reactions. These hypersensitivity reactions result in several things. They result in airways that become edematous, resulting in inflammation, #1. Now, this is a biggie, and I've got it bolded. And the reason I have this bolded is because now researchers are saying if you can get it when it's at this point before it continues on, then you can control it a lot better. So now the evidence-based research says that as soon as they come in, we need to start some type of steroids so that we can get that inflammation down and keep this congestion down and keep these from constricting and keep the air trapping from occurring. So again, this one leads to this one, leads to this one, leads to this one. So if we get it stopped here, then we'll decrease this from occurring. Now, ancient Egyptians, this dates back way back in time, actually used camel or crocodile dung that was burnt on herbs with hot milk, and the patient would inhale these fumes, and that would help with asthma. That's just a little fact. The word asthma itself means panting, and because someone who's having a true asthma attack will look like they're panting, and that's because they're fighting to exhale. Those bronchioles become so constricted and the airways narrow so much that it actually puts them into spasms. Now, there are two types. There are the intermittent versus the chronic. Intermittent is when you have symptoms that you may have attacks every 6 months. You may have an attack every year. Whereas chronic is someone who requires frequent or continuous medication therapy. They are having attacks quite frequently and actually have to be on maintenance therapy. When you get ready to do a nursing assessment, you're going to be assessing a lot of things. First, you want to look at the history. Is this intrinsic or extrinsic? And extrinsic would be the allergic type. They're usually allergic to something, and that allergen triggers an asthmatic attack. Now, intrinsic is non-allergic type, idiopathic. So sometimes we have no idea what causes that. Exercise-induced, it can be exercise-induced as well. And the majority of people have what we call mixed or combos, and this is the most common type. As far as looking at a history of allergies, you would want to look at their environmental exposures that they have, secondhand smoke, viral illnesses, certain chromosomes, cockroach feces, chemical gases. And there's other triggers on page 737 in your book in box 23-15. So you can read over those as well. Home environment, you need to look at that. Does it have pets? Does it have carpet? Are there allergens in the home? Do they say they're allergic to cats and they have a cat in the house? They complain often of a tight chest with a non-productive cough. Also, one of the big things, the hallmark sign, is actually wheezing. And this is expiratory wheezing. And usually you don't even need a stethoscope to hear this wheezing. You can hear from across the room. Now, asthma is a scary thing. There's about 5,000 deaths per year from asthma because the air forces through those fluid-filled narrowed airways that we talked about up there earlier, and you're actually fighting to exhale. So someone with asthma usually has a normal inspiratory, but a prolonged expiratory with wheezing. Their chest diameter enlarges, and that's a late sign. They have an increased number of school days that they miss, which we talked about earlier. And they have signs of respiratory distress and shortness of breath. So the three common symptoms you're going to see are dun, 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 cough, shortness of breath, and wheezing, and you need to know those. Analyzing this, the main two nursing diagnoses you're going to see is impaired gas exchange and ineffective breathing patterns. So how do we go about diagnosing? Well, one of the things that they're going to do is do a chest x-ray, and they're going to see hyperinflation of the airways. And if you were to do percussion on them, you would hear hyperresonance. Now, another thing is the peak expiratory flow rate. And I have a YouTube video. You need to watch this. Also on page 738 in your book, it talks about it. It says you need to be older than 6 years to use it. Some people will say 5, okay, as young as 5. So you're really going to have to do an assessment on the child to see, but somewhere between 5 and 6, they would use this peak expiratory flow rate depending on maturity. Now, what this does is measures the greatest velocity of flow that can be generated in a forced expiration. And you'll see that when you watch the YouTube. You start with fully inflated lungs and you figure out what is your personal best by blowing into that 3 times in a real strong puff. Your highest reading is considered your personal best. Now, if you look on page 738 in your book, it is set up like the red light system. Just like a red light system, red means stop, yellow means caution, and green means go. So let's say you had someone who blew into the peak expiratory flow rate meter 3 times as hard as they could, and the highest they could blow was 400. Well, you would set that little red bar at 400 as being their personal best. Then you would take that 400 and multiply it by 80, because that would be 80% of that. And if you do, you'll get 320, and that's where you would start your yellow zone. Then you would take 50% of that, which would be 200, and that would be the end of your yellow zone. So anywhere between 200 and 320 is the yellow zone. That means caution. If they're above 320, they're at 80 to 100% of their personal best, and that means they're in the green zone, and green means go. If they're in the 50 to 80, that means yellow zone, and they need to stop and consider what they're doing. If they're less than 50, they're in the red zone, and they need emergency medical assistance. So know the chart on page 738, interpreting peak expiratory flow rates. Wheezing and dry cough. Now, can no wheezing be a bad thing? Let's look at the nursing alert on page 738. Shortness of breath with air movement in the chest restricted to the point of absent breath sounds, what we call the silent chest, accompanied by a sudden rise in respiratory rate, is an ominous sign indicating ventilatory failure and imminent respiratory arrest. So yes, in fact, no wheezes is a bad thing, especially if you've had someone wheezing like a freight train and all of a sudden they're getting quieter and quieter, but the respiratory rate's going up and up. They are fighting to exhale, and now they've about closed off. The use of accessory muscles for respirations leads to that barrel chest that they get as they get older. They may have some pulmonary function study tests done, and there's a blurb on page 738 that you can research on your own about that. So what about the nursing planning and intervention? Can asthma be considered a reversible disease? Absolutely, yes. In fact, a lot of children outgrow it. And once they outgrow it, when you go back and look at their lungs and stuff, they'll be fine. You want to monitor carefully for increasing respiratory distress. There's actually a severity classification system on page 736 in your book for ages 0 to 11. Now, this, when you look at this, you will see there that they have steps. Step 1 meaning intermittent asthma, step 2 mild persistent, step 3 or 4 moderate persistent, and step 5 or 6 severe persistent. So you can see if you start reading under each one of those that their peak expiratory flow rate's getting worse and worse, that they're having to take their medicines more and more, that their symptoms are more and more. So they're just showing increasing symptoms as you're going up the steps and needing more control. You can want to know these in general. You don't have to know them specifically for the tests and everything under them. You want to administer rapid-acting bronchodilators and steroids for attacks. Why the steroids? Because we want to catch it in that first phase and keep it from progressing on. Maintain hydration, monitoring ABGs. And what will we expect to see? Respiratory acidosis. Go back and review the pH, bicarb, and CO2 if you don't remember the norms. You want to administer oxygen and nebulizer therapy as prescribed. And remember to monitor the pulse ox reading. Remember, 95% or greater was normal. At home, you're going to be doing lots of the teaching. You want to make sure they know what's precipitating these factors and that they are avoiding those factors and that they're doing things to reduce allergens in the home. Do they know how to use their metered flow inhaler correctly? Are they monitoring peak expiratory flow rates at home? Are they doing their breathing exercises? Are they monitoring drug actions and doses and side effects and seeking medical care when they need to? And then referring them if they do need some type of emotional or psychological counseling as needed. Now, there are two main classifications of drugs, and they are relievers and controllers. And controllers are just that, or preventers. They're on things that you use maintenance dose to help you stay out of trouble. They're not ones you want to use when you get in trouble. Now, the relievers or rescuers are ones you want to take when you're in trouble. There are four major categories: bronchodilators, anti-allergic mediator agents, also known as your mast cell stabilizers, your anti-inflammatory agents, and your leukotriene inhibitors. First, we'll talk about the bronchodilators, and these can be short-acting or long-acting, so in other words, they can be relievers or controllers depending upon what you need them to be. One of the prototypes is theophylline, which we don't see that as much as we used to use them years ago. Now, if it's given PO, it's considered the long-acting. In its short-acting form, it's known as aminophylline, and it's given IV. One of the things you want to do is check blood pressure because it does affect blood pressure, and know the normal levels. They do have to draw levels when you're on theophylline. You want to keep it between 10 and 20 to be therapeutic. If you get it above 20, you're going to be seeing early signs of toxicity, which are nausea and vomiting. And above 30, you're going to actually get into cardiac arrhythmias. Epinephrine, the two main things you want to warn them about is they're going to have tachycardia and palpitations as a side effect. Your beta antagonists, like your Alupent, Proventil, Ceravent, those medications also cause increase in heart rate and increase in hyperactivity. So you've got a child who's on Alupent updrafts. They may be bouncing off the walls in the room, and we need to let parents know that that's part of the medication side effects. Now, how do I know these meds are working? Well, they were wheezing like a freight train, so if I hear decreased wheezing, that's a good sign. If they're breathing easier and respiratory rates going down, pulse ox is staying up. So all those signs and symptoms that brought them in, if they're starting to improve, lets me know the medications are working. The anti-allergic mediator medications, the non-steroidal anti-inflammatories, are mostly controllers. The prototype is cromolyn or Indol. Now, it can be given via nebulizer as well. If it's given in the nebulizer or the inhaler part, it's mostly in the form of powder, and people complain that it does give them a bad taste in their mouth, can irritate their throat, and cause some coughing. As far as the anti-inflammatory agents, controllers, these can be IV to be relievers as well. This would be like your corticosteroids. Now, they have the common side effects we know: immunosuppression, increasing blood sugar, thrush, long-term growth suppression, and are known to be controversial as far as the long-term growth suppression. The leukotriene inhibitors are one of the newer ones, and the major advantage is they can be given PO. All these other ones were either IV or inhalers, and this one's PO. Your Accolade, Zyflow, and Singulair are your most common. The Accolade is given with meals, and you have to be 7 or older to take it. The Zyflow is 4 times a day, and you have to be 12 or over because it can cause some potential liver problems. Your Singulair is given once a day in a chewable tablet, but it can be as young as 12 months and older. Of course, they're not going to be able to chew it real good, but you can crush it for that young age. Now, you want to know which medications belong to which categories for the exam, and that they are usually on a maintenance medication schedule. If they are on a maintenance medication schedule, they will be on one inhaled corticosteroid and one short-acting bronchodilator. So if they are on these two inhalers, which one would they get first and why? The inhaled corticosteroid would be given first, and the reason is you want to get down there. The bronchodilator would be given first because you want to get down there and open everything up so that the inhaled glucocorticosteroid can get down there and help that inflammation and help it from getting to the point that they go into an asthmatic attack. Now, some of the newer meds, the Advair, the Xolair, these are a lot of your discus. You have to hold them almost like a little hamburger when you're doing it and activate them. And I have given you some videos to watch on that on the YouTube. Please watch these videos because it's very important. Now, this one has a black box warning and it's given sub-Q, so that's a little bit different. Black box warning means that someone's had an anaphylactic reaction to it. So, last but not least, what is status asthmaticus? It says here, feels like a fish out of water. They're sitting there flopping, they want to breathe, but they can't. It also feels like you're in between two walls and you're just squeezing in on you and you cannot get out. Severe asthma that's unresponsive to conventional therapy that lasts longer than 24 hours. Now, this is always potentially life-threatening because it tends to intensify and progress once it begins. Treatment, you're going to be dragging out the glucocorticoids, the bronchodilators, the beta antagonists. You're going to be giving an IV. You're going to be giving nebulizers, O2 and IV fluids. If they get to the point they need mechanical ventilation, you will have to trach them instead of putting in an ET tube because they have so much restriction that they're hard to intubate. Antibiotics, in case something has triggered that as well. Nursing considerations, you want to make sure you administer their meds as ordered, monitor their vital signs, explain what's being done, teach them the proper use of the peak expiratory flow meter, make sure you're doing good discharge teaching, and this is a key, continue to take your meds even if you're asymptomatic. Now, that's hard to teach some adolescents with asthma. They think they're doing fine, so they don't need to take their meds every day, and then they get in trouble. So continue to take your meds even if you're asymptomatic. So prevention's the key. You need to know this content for the exam. Email me if you don't understand something. There are 50 questions in the Peds section from the content I will be covering. So if you need any concerns, please let me know. Thank you.